campaign for accessing blood sugar levels in 1 million individuals. She's also a social media influencer to create awareness about medical ailment. So we are very happy to have her on this webinar, and we are having this particular webinar. MedGenome is hosting this for the tuberculosis. In March, we have multiple activities, including CMEs and webinars, and this is one of the activities. So it's a pleasure to have her. Dr. Honey, over to you. We can see your slides. Perfect. Please go ahead. Yeah, thank you.
Okay. Yeah. Thank you so much, Dr. Gunisha, for the kind introduction. And you have been a mentor to me for this WGS, and all that knowledge which I've gained has been because of you and Dr. Rajesh Roy. And it has been pleasure working with you. Now, talking about this innovative technologies, first thing is, why do we need them? So the reason for needing them is very clear, that Mumbai especially, and India as a country, is a hub of drug-resistant tuberculosis. And even today, we have a lot of treatment failures. We have patients dying because of drug-resistant tuberculosis. And on the other hand, we have the time where we actually wish to end tuberculosis by 2025. In order to achieve that goal, we need to work hard. And for this, such innovative technologies will help us to achieve. And to actually highlight this in a very practical way for all the physicians and ID specialists, I will be starting with a case study. And this is a very own case of mine where we have used this innovative technology, and that has reformed how we can treat them. So this was a 30-year-old gentleman, IT professional, who presented with the complaints of abdominal pain for 1 month, loose motions with fever on and off, weight loss of 10 kgs over 1 month due to loss of appetite. He was admitted under my gastro colleague and was investigated thoroughly for the loose motions. CBC was suggestive of pancytopenia. The blood culture and stool cultures were negative. The stool test for C. difficile was negative, and that's where the patient underwent stool testing for opportunistic organism. Now the thought process here was, patient has pancytopenia. There are chances he may have stool infection with opportunistic organism. It was found to be negative. He continued to have fever and loose stools, and then the doctor planned for colonoscopy. During his pre-op evaluation, he found that the patient was HIV-1 reactive. On further testing, it was found that he had a viral load of 224,000 copies and a CD4 count of 48. So this is clear cut. We are dealing with a patient who has got fever and loose stools, weight loss, who is HIV reactive with a CD4 count of 40, so has got some opportunistic infection, which has led to this condition. In mind, colonoscopy was abandoned, and CT chest and abdomen was done as a priority. We saw that patient has multiple necrotic lymph nodes, enlarged spleen with spleen abscess, free fluid in the abdomen. Patient was referred to me for further management. I had a suspicion of tuberculosis looking at the CT scan. X-ray also had shown miliary tubercles. So I decided that to go further dig into this HIV thing, and that's why we did a CD4 count which was low. So we did a CMV viral load to rule out CMV colitis. It was found to be negative. Fundoscopy was done to rule out if there is any retinitis. It was normal. VDRL was negative. Other viral markers were negative. I went ahead and planned a lymph node biopsy, CT guided, for this patient. The samples were sent for gene expert TB MGIT during this stage. And the report came the same day, where the lymph node sample was tested positive for Mycobacterium tuberculosis, and it was rifampicin sensitive. This patient, we almost thought that we have got the right diagnosis, and that's why we started him on first-line AKT drugs. Now, for HIV positive patient, the first thing that we do is we start AKT, and then we introduce the HIV treatment. So meanwhile, the supportive treatment for diarrhea continued, and patient gradually improved. He was discharged in stable condition, and his fever and abdominal pain gradually improved. So after starting the AKT, fever subsided and his abdominal pain subsided, as well as the diarrhea subsided. So this patient was then discharged in hemodynamically stable condition with drugs HRZE. That is isoniazid, rifampicin, pyrazinamide, and ethambutol, which is a regimen we follow for everyone. 2 months after his beginning of treatment, he was in constant follow-up, in which he was doing well. 2 months after his starting his AKT, it was the time that now I pay attention to the the culprit behind the HIV, and that's why I decided to start him on ART, that is his antiretroviral therapy. We started him on dolutegravir-based regimen. As you know, rifampicin induces dolutegravir clearance, and that is why dolutegravir dose needs to be doubled. Now here, WHO guidelines clearly state that if patient is doing well after 8 weeks, you can start AKT for the patient, ART, that is HIV treatment for the patient. But problem is what I faced. In retrospection, I will tell you what were my thoughts. So 4 weeks after starting his ART, patient started developing again the abdominal pain, weight loss, loss of appetite, cough, breathlessness, lymph nodes were enlarged, splenic abscesses became worse. I had been very sure about his compliance because there was a sister who was the informant, was closely watching, and the patient was educated and nice chap. He was definitely wanting to recover. He was taking the treatment regularly. Now, this patient was really sick. He had become hypotensive and hypoxic. I did a CD4 count, it was further low. And that's why I just understood one thing, that if this has occurred after ART, mostly what we are dealing with is immune reconstitution inflammatory syndrome. That is, we were dealing with IRIS. He had elevated liver enzymes and bilirubin, bilateral pleural effusion, worsening splenic abscesses. So definitely it was TB IRIS that we were dealing with after starting of ART. And hence we decided that we will first do one thing, we treat the IRIS, and on the second time, we will not stop our ART. We will not stop our TB treatment, but we'll modify. So based on that, I modified the treatment, put him on levofloxacin, injectable aminoglycoside, and ethambutol. Started him on prednisolone 20 mg twice a day for IRIS. And gradually, I saw that as soon as the steroids were started, the patient improved clinically. That further confirmed the diagnosis of IRIS. Patient started improving and he was discharged. And even on follow-up, he continued to do well. He was doing well, and that is when his liver enzymes had settled down and his LFTs improved. So I decided to re-challenge with rifampicin and isoniazid. He tolerated this challenge very well. His liver function continued to be normal. His steroids stopped after 2 months, of course, with gradual tapering. He continued to gain weight and was asymptomatic now. We reached towards the 6 months of his antiretroviral as well as his anti-tuberculosis therapy a little more. And CD4 count was repeated. It was found to be 340. His viral load was not detected. His ART was not stopped at any stage. Then, of course, now I was very happy because my patient was doing well. Patient was not requiring further admissions and everything was fine. So, of course, it was a feeling that now this is his end of his treatment and we wanted to investigate accordingly. But we were wrong. This was not as happily ever after, because towards the end of his TB treatment, patient again during his follow-up, when after 1 month I was almost going to stop the AKT, that time the patient came to me again with the similar complaints of fever, abdominal pain, and weight loss. Now this was absolutely confusing because IRIS does not stay for so long. Patient's steroid was stopped more than 4 months back, and still patient continued to have symptom. His CD4 count was good, viral load was not detected. And then we, of course, did ultrasound simultaneously, where we saw that he had new development of psoas abscess along with splenic abscess and lymphadenopathy. So, of course, without wasting any time, I knew that probably we are dealing with some new infection or failure. I planned for a psoas abscess drainage and testing immediately. Now, here I had questions in my mind. What was I dealing with? Was it a treatment failure? But this was a compliant patient who was taking all the medicines regularly, good medicines, as well as he was on the right regimen, according to me. And also, patient was doing well on his ART part, on his HIV part. So was it a new infection that now the patient has improved, but because of re-exposure, he has developed a new infection? Or was it a dual infection, that is hetero infection, that is two clones of mycobacteria in one patient where one is resistant and other is sensitive to rifampicin? So probably this was what we were dealing with or what we didn't know. So first thing is we did a gene export on the psoas abscess pus which was drained. It was again positive and mine as well. It was rifampicin sensitive. I decided to start on 4-drug AKT again. ART continued with dolutegravir twice a day. There was no growth in his TB-MGIT at the end of 6 weeks also. I reopened the old file, but TB-MGIT had shown no growth then also. So I thought probably the culprit was rifampicin not reaching to an adequate level in his body. So I did rifampicin trough level, but they were also normal. So now everything is going well. patient is rift sensitive, he's on the right regimen, but he's kept on building psoas abscess. Like every week, we used to end up draining it. So this time we decided we'll not miss on line probe assay. So I immediately sent line probe assay in the same sample. And to my surprise, this was one important thing which was missed. That patient was having monoresistance to isoniazide. He was rift sensitive. So I think the clue was solved, puzzle was solved, the pieces were now together and treatment was adjusted. Isoniazide was replaced by fluoroquinolone and same regimen followed. ART continued, dolutegravir twice a day. Now everything seemed perfect. Patient stopped having fever for a few days only. Unfortunately, this was not his happily ever after because this patient continued to have symptoms of psoas abscess requiring multiple drainages, fever, weight loss, and in spite of being compliant, in spite of viral load being negative, he was absolutely not responding to the treatment. Finally, we did a pigtail insertion, and that's when I raised to MedGenome that whether we can do a whole genome sequencing for this patient who is culture negative. Now, every time I did his culture 3 times during this process, and every time the culture used to not show the growth of mycobacteria. And that is where I was lost because I could not do culture sensitivity, drug sensitivity testing. And since I could not plan his therapy and label him as what, because he was always rift sensitive. So what kind of tuberculosis was it? MDR, XDR, or just drug resistant tuberculosis? So now there were two options. Either I do LPA for first line and second line. First line was already done. I do for second line, or else I go for something more comprehensive. So considering the cost involved was almost equivalent if I go for whole genome screening or LPA, the turnover over time will be more with WGS. I decided and I spoke to MedGenome people and I decided that we'll go for whole genome sequencing. Now, whole genome sequencing has a big advantage that it is culture free. It does not require the mycobacteria to be positive on the culture or growth to be seen on the culture. Even if your gene expert is positive, the same sample can be sent for whole genome sequencing. And definitely it was a game changer for the treatment. As you can see on the screen, the report, the reason why my patient was not responding is because he was not just resistant to isoniazide, he was resistant to ethambutol and pyrazinamide also. And he was receiving only one drug which was sensitive, and that was rifampicin. And one drug, as we all know in tuberculosis, do not show good effect. Or maybe two drugs, levo and rifampicin together in intensive phase, were not able to make difference to his treatment. So that is why we went through this 20 drug susceptibility testing. And thanks to this comprehensive testing, we could actually know that rifampicin was a useful drug. Levoflox was a useful drug. We could use linezolid because linezolid, as you can see, has mutation of uncertain significance. So there are two things with this report. One is to understand that there is a mutation. And second thing is that whether that mutation is clinically significant. So MedGenome, based on its library, gives us a clear-cut report where it says that whether it has been associated with resistance or not. So as you can see, the mutation is seen with linezolid also, but it is of uncertain significance, and that is where linezolid can still be used for the treatment. Same thing goes for clofazimine. So only those mutations which are clinically significant should be taken, and those which are not significant or not associated with any resistance in the past can be not given importance. So as you can see, it is so surprising that aminoglycoside, amikacin is not having a mutation, but for streptomycin, there is a mutation which has been associated with resistance. So this is such a individualized treatment where which aminoglycoside of the two can be used is also specified. So based on this individualized report, we created an individual tailor-made treatment for this patient, and he was started on rifampicin. I didn't want to give up on the advantage of rifampicin because he was always sensitive, even on WGS. Added levoflox, injectable amikacin, and linezolid and clofazimine to his. Now his ARTs continue with dolutegravir twice a day because rifampicin is part of our treatment. So this is how the whole genome sequencing was a game changer for me because it helped me to understand that which drug can be actually used for this. And especially so it came to my rescue when culture was not coming positive and I could not do DST. So patient is now clinically better. His fever has stopped. He has weight gain. And now when we talk about this, it is already 4 months and his ultrasound is not showing any new abscess and the older ones have resolved. And I'm hoping that maybe this is his happily ever after. And luckily, now because of this whole genome sequencing, I have my backup plan also ready. Because if these drugs also don't work tomorrow, I have a data of some other drugs also which are sensitive and which can be used in future, which can come to my rescue for this patient. So this was about whole genome sequencing and how it turned out as a game changer for me in treatment of my patient who has HIV and TB. As such, as clinician, as a physician who likes to treat infectious disease, I have experienced that HIV and TB when it is together, it's a difficult story. In this, multiple issues come up. To diagnose it is difficult, to treat is difficult, and resistance rate, in spite of being compliant, are very high. Treatment failure and chances of not surviving the whole thing is also very high. So whatever acts quick for us, whatever gives us quick results, and individualized tailor-made treatment is going to be a benefit for all the patients who are drug resistant, especially so those who have HIV and TB. So now talking about this whole genome sequencing, which we used with which was actually a product of MedGenome. The history of this is that it was founded in 2013, and the first provider of NGS to the Indian market has been MedGenome. It's India's market leader in genomics, and there are a lot of research data and evidence available for whatever genomic tests they provide. The first WGS sequence-based test directly in the clinical sample, which has been validated on pulmonary samples, but the same validation has been applied on extrapulmonary samples, like we did for my patient, and it has proved to be equally effective. It's a culture-free technology. You do not need the growth of bacteria on the culture every time. Gene expert positive can also be sufficient. It's a rapid test. The turnover time is 6 to 8 days. Maybe this is a little bit of theory. 14 days is a practical turnaround time. It can not just tell you the speciation, just not tell you the mycobacteria, but it can also tell you the mutations associated with drug resistance for 20 drugs and beyond. So it is, I think, the answer of current drug-resistant tuberculosis pandemic, which is going on. In that, I think this is going to be a game changer. It is going to be answer to a lot of our queries. Like we treat other or infections based on their blood culture. Suppose we do a blood culture and we do a DST, and based on DST we treat the infection. But for tuberculosis, like since ages, it has always been a treatment which is which has been based on regimens given by research and which is by evidence, backed by evidence. But now you have an individual data for each patient and you treat accordingly, which makes world of difference. It helps you to confirm your diagnosis. Spit sequence, spit XQ helps us to confirm our diagnosis of Mycobacterium tuberculosis and also help us to predict drug resistance from day one. It has a comprehensive drug panel which covers 20 drugs, and it can be done directly on the clinical specimen. It can also be used for research purpose. Sensitivity is 100%, specificity is 98%, and there is a huge validation data backing whatever we have told today. And this has been done at 3, 4 hospitals, major hospitals like John Hopkins and Hinduja Hospital and all. So it has nowhere been a tool which is being used without any data or without any scientific evidence. It has the backing of good amount of data. So this is the article which you can all read through, and it has been done at real good top hospitals which treat infectious diseases. Even it has been mentioned in pulmonary journals, also international journals, where they have told that targeted next generation sequencing is going to be the army knife for mycobacterial diagnostics. If we improve diagnostics, we improve the treatment. I believe in that. And the faster the diagnosis is established, the faster the sensitivity is established, more is going to be the survival rate for our patients. How does it work? So the sample is given. It goes to the genomic analysis where DNA is extracted, the library is prepared. Target which we want to see is enriched by hybridization, and then sequencing is done for that target, and analysis of mutation is done on that sample. And based on that, a report is generated, which you have already seen a sample copy. So what are the drugs covered in SPEED CQ for the first line? As you can see, all the first lines are covered. When you do an LPA, the first line LPA just covers RNH, that is isoniazid and rifampicin, but here all the first line drugs are covered. Second line drugs are covered, all group A, group B, group C drugs, and plus other drugs which come to our rescue when we are in tough situation are also covered over here. And identification of mutation analysis is done, and whatever mutations are clinically significant are mentioned and which are not significant are also mentioned in the report. As we all know, tuberculosis is a major concern in India. The speed sequence NGS based whole genome sequencing is a test where prediction can be done from pulmonary extrapulmonary sample. It reduces the time delay because the culture takes 45 days to declare whether the growth is going to occur or not, and after the growth occurs, it takes another 2 weeks to do a DST. So here it is the time which is very crucial, and that time can be saved. And in fact, if you compare the cost of whole thing with doing just WGS at the beginning, it's comparable. You are saving time and you are spending same amount of money, or maybe a little more, not a huge amount, or not a huge amount, which is more. Clinical reporting is superb and the interpretation is given very well. Mutation databases are absolutely backed by evidence and WHO evidence. It is evidence not by anyone else, but a domain has been public domain, which is done by WHO and is updated periodically. It can predict lineages of Mycobacterium tuberculosis can be more virulent or drug resistant than others also. It can tell you XDR and true MDR cases. It can also tell you about heteroresistance. This was the one reason, because I have been asked by people, why didn't I do LPA directly, or why didn't I do pyrosequencing? So the reason is that heteroresistance would not be picked up by them, but WGS can pick up heteroresistance for me. And that's how I can label the patient as drug resistant MDR, XDR, and tailor made treatment can be made. Now, advantages versus traditional advantage, as I can tell you very easily, the strain typing can be done with whole genome sequencing early. It can be done by culture technique, but of course, it takes time. Drug resistant testing, it can be done by culture, can be done by WGS, it can be done by CBNAT, but giving 20 drugs at a time is not possible for all of them. Newer drug resistant mutations also, as you can see in very well, bedaquiline as well as delaminide were also included in the 20 drug susceptibility report, sample report, which I shared. The best type is turnaround time. It's 10 to 14 working days. As I told you, when it comes to culture, it can go up to months together. And then you know what is happening. And when it comes to sensitivity, whole genome sequencing is 100% sensitive. LJ media sensitivity is little less. NAT, CBNAT, and all other molecular testing, as well as LPA, the sensitivity is great, but still it is 95% as compared to WGS, where it is 100%. Specificity is 98% as compared to LPA as a reference standard. For LPA, for rifampicin, the sensitivity is 90% for rifampicin and isoniazid, and it is 98% for the fluoroquinolones. So definitely, it may not be very, very superior to LPA right now, but if you look at drug-resistant tuberculosis cases, it is definitely superior to LPA, and that's why it can be a game changer in this sequence. This is how the test works. This is how the report comes, a sample report, and on the right, the test code. And what is it called? It's called a speed sequence, and method is next generation sequencing, where we do a targeted whole genome sequence. Test results are given as positive, negative first, and then the drug resistant panel is given. Turnaround time practically is 14 days. It can be done on pulmonary, extrapulmonary sample. The only prerequisite is that the gene expert positive report should be there, or smear positive report should be there. We don't wait for the cultures over here. Transportation rules have to be followed as mentioned. The sample should be transported 2 to 8 degrees Celsius within 24 hours of collection. And if it cannot be transported within 24 hours, it should be stored at minus 20 degrees Celsius on dry ice, or transported on dry ice. Validation, it has been validated well, and I have already shared the articles for the same. So speed sequence, the direct sputum-based whole genome sequencing test has been validated. The same can be applied very well on the extrapulmonary samples also, and the results have been really rewarding. So this is all about speed sequence today. And with this, I come towards the end of my talk. With the case study and the information on WGS, I'll be happy to take questions if any.
Yeah, thank you so much, Dr. Hani, for this wonderful talk. And very nicely, you have elaborated like on the case study part, and finally, the patient got the happy ending, I believe so. And end of the day, ma'am, like you have nicely elaborated on how SPITSIC works and how it helps in the drug resistance in tuberculosis. So the floor is open now. So I request the participants to post their questions, because it's a Zoom call, so you can post the questions in the Q&A section, and Dr. Hani and Dr. Gunesh would be happy to answer the questions. or you can raise your hand. I'll just try to unmute the participant if somebody wants to ask question directly. Acha, meanwhile, if Dr. Kunisha is having some questions, like, or you can ask Dr. Hani so that she...
Right, at a really excellent presentation, Dr. Honey. And I think you've highlighted all the important points which I would want to highlight, especially coming from MedGenome. I think you've comprehensively covered all the uh, points. Do you have any questions, any technical questions for me, Dr. Honey, so that we could give tell it out to the audience?
Yeah, yeah. So as we had discussed these questions when we were handling this case, I wanted you to tell me that targeted NGS, which National Tuberculosis Elimination Program is working on, how different it is from the whole genome sequencing, and which, according to you, can we have an apple to apple comparison between the two?
As I had mentioned when we discussed earlier, WHO has come out with a rapid communication some time back where they have said that NGS-based tests, targeted NGS-based tests, could be used now directly from clinical samples. Earlier, WHO recommended that only, whole genome sequencing or NGS-based techniques could be used only from culture DNAs, mainly for surveillance. So we were happy with this rapid communication. Now it would just take some time, I think, NTP to adopt this particular into the program. What we have is something called a whole genome sequencing based, and what WHO is approved is a targeted, which are amplicon based. I think NTP is going to do its own evaluation as to what particular test would be suitable for Indian market, considering we would require this test to be available in 3 tier, 2 tiers, and as well as the rural areas. Recently, I was in the TB Innovation Summit, which was there couple of I mean a week or 10 days back, where MedGenome was also part of the innovations which were offered, and we had proposed this particular test. So we are hoping that this test or similar tests will be adopted by NTP soon, so that the benefits of this test could be used widely by the doctors, and because they always wait that such tests are, if they're in the program, they would be better acceptability. So I would say the WGS based are better than the targeted one, because we sequence the entire length of tuberculosis genome, which is 4.4 MB. So we are not, in case there are new catalog of mutations which are come out by WHO, which we are expecting very soon, we don't have to make changes in our kit, or we don't have to make any changes in our lab protocols. It's just that we have to update our database with more drug resistant mutations as and when they are given by WHO.
Okay, great. I think this would be a game changer.
Yeah.
And just as a thought, because now as a clinician, I have seen a paradigm shift. We are getting naive tuberculosis resistant cases, drug resistant tuberculosis, completely naive. Like they have never had TB, never exposed to anyone in the family who had TB. So in those patients, when I get a gene expert positive, that time I usually send LPAs. So if I directly send WGS, what will be advantage that I would feel I would have actually with that? Like, will it be a right thing to do beforehand, or should I just wait for a treatment failure? What are
I
your
think
views?
I think we should not change. What I mean is, I think immediately after a gene expert is positive, you should not wait for LPA. You should not wait for a culture to grow. If you want the right treatment, especially when it comes to drug resistance area, or especially in Mumbai, then where the MDR transfer, as you mentioned, to the naive patients, then please do not wait for it. Just order for a comprehensive whole genome sequencing based. You can get maximum 10-14 days a comprehensive view. Otherwise, if culture is positive, but it will take 4 to 6 weeks by the time you have a comprehensive or kind of a view of 12 to 13 drugs, which is again very expensive. So amount of the burden, which economical burden, which will be on the patient, will be immense, because luckily, if the answers are given by LP or the culture, it'll be great. But if not, if like it's something too similar to your case, where Gene Expert was done multiple times and then you had ordered LPA, it took so much of time, and probably, the economical burden on that particular patient would have increased. So
Yeah.
in such cases, I guess a direct order, if it is Gene Expert positive or a TrueNAT positive or a smear positive, it should be ordered immediately.
Great, great. I think that that should be the norm right now. Of course, it will take some time to have the
Right,
shift in our thing, but
right.
definitely we have understood that TB has always left us with clueless many times, and that is why we need to be little more prepared when we are handling tuberculosis cases nowadays. So we had spoken about the interpretation of report where mutations of uncertain significance have been mentioned for linezolid as well as levoflox. So what is your take on this, and how is that decided?
This particular grading is given by WHO, associated with resistant, interim, or uncertain. Uncertain significance means there are not enough correlations or enough strains which have been studied, or the correlating phenotypic drug susceptibility results are not available for them to grade it with confidence. So they think this could be responsible for some mutation, but unless they have that correlation with the phenotypic with more number of isolate, they do not do it. So in the first catalog of mutation, I think all of this results, which was published by WHO, was around 38,000, where WGS was done along with the phenotypic drug susceptibility. When they released the second version, it was like 58,000 isolates, and phenotypic drug susceptibility and the mutation analysis was done. So for certain mutations, the number of culture isolates were not enough, or there are particularly some rare mutations, or they have limited clinical data, or they have some unclear effect on gene expression. All of these mutations are categorized uncertain. So I would just want to add to this, in the first catalog of mutation, many of them were uncertain, categorized as uncertain of significance, especially for the newer drugs like bedaquiline, linezolid, and delamanid. And fortunately, for all the patients, the number of mutations have been added in the second one. So all those uncertain mutations now are categorized with associated with resistance or with interim. So this is actually game changer, especially when the BPAL regime is being rolled out and all of that. So probably uncertain significance now could turn into associated in the third one. So there's not enough evidence for them to categorize, and that is why they're mentioning that.
And how regularly is this updated?
So I think what we are seeing now, every 2 years, I think first one had come in 2021, and the second one came November 2023. So they're regularly 2024, I think. So they're regularly updating 2.5 years. But what I hear from inside sources that another one is coming soon.
Oh, okay,
Yeah.
great. And I wanted to know because we have been all happy about the results which we got and our patient getting improving actually. But what are the limitations of, because after all it's a genome sequencing, and as we know PCR has given us that idea that there is a lot of noise, even if you're looking at a specific organism and a syndrome, still there is a lot of noise, unnecessary organisms come positive. Does that same limitation hold true for whole genome sequencing also?
I don't think so. There's a lot of background problem because we are here enriching the MTB genome completely from the clinical sample. So for any test to work good, or is enriching. So either enriching can be done by culture, or it can be done by PCR, or could be done like a hybridization. So hybridization is a technology which we use for enriching. So you mentioned that mixed infections or something like that, or a background will not have too much effect. Yes, and sometimes it happens, especially when the bacterial load are low. So I mean, it correlates. This particular test correlates really well when gene expert low and above. But when it comes to which is very low, and sometimes when it's trace, then it becomes tricky when we do not get the entire coverage of the genome. So it becomes tricky when the the bacterial load are low, And in terms of just mentioning about the limitations, I think adopting this particular technology, I think the infrastructure now, thankfully, because of COVID, the PCRs and RT-PCR machines are available, but obviously NGS machines are still not available. So one limitation to actually adopting this across into the TB program and taking out to the rural areas would be, the cost involved in having these machines. But fortunately, there are low cost sequencing machines are also which is coming up, which could be helpful. Something like the bioinformatics capabilities are also new. We have designed a bioinformatics pipeline which is in-house, which is dealing with all the data which we do. So bioinformatics capability is something which might not be available for such tests to be implemented. However, there are solutions now, especially